So, sarcoidosis is a chronic disorder of unknown cause. Unknown cause. It manifests with non-caseating granulomatous inflammatory foci. It can affect any organ system, but the lungs, lymph nodes are the most commonly involved. Lungs, lymph nodes. More frequently affects patients of black than white ethnic background in a ratio of 10:1. More common in colder climates. One of the most common systemic association of uveitis. So in 1909, Hereford described the first ocular manifestation of sarcoid in 3 men with uveitis, parotid enlargement, and fever. Systemic features, the presentation. There are respiratory symptoms like cough, shortness of breath on exertion. Constitutional symptoms, which are malaise, arthralgia, each occur in about 50% of patients. There is a Lofgren syndrome, an acute presentation carrying good prognosis. There is a triad of erythema nodosum, bilateral hilar lymphadenopathy on chest X-ray, and polyarthralgia, usually seen in women. A minority of patients are asymptomatic, incidentally abnormal chest X-ray. Diagnosis may be made as the result of investigation of extrapulmonary inflammation such as uveitis. So uveitis may be the first sign. Lung disease ranges from mild parenchymal infiltration to severe pulmonary fibrosis. Here you can see mild disease, and this is mild to moderate, and this is severe pulmonary fibrosis. Bilateral hilar lymphadenopathy, reticular opacities, volume loss. Skin lesions are seen in about 25% of patients and can include erythema nodosum, which are tender erythematous plaques typically involving the shins, as you can see in these pictures. Lupus pernio, which is indurated violaceous lesions involving exposed parts of the body such as nose, cheeks, fingers and ears, and granulomatous papules or macules. Skin of the face shows multiple maculopapular lesions with a flat, waxy top. At the nose, they are bullous. So this is a sarcoidosis patient. Neurological disease is rare, but meningitis and cranial nerve palsies may occur. Pituitary involvement can lead to hormonal abnormalities. Cardiac involvement is relatively uncommon, occur in 5% clinically, but is critically important. It may lead to arrhythmia and sudden death. Lymphadenopathy, enlargement of superficial nodes, is sometimes the initial clinical manifestation. Ocular features, ocular inflammation occur in 25 to 70% of sarcoid patients depending on the ethnicity. Granulomatous anterior uveitis and conjunctival nodules. Granulomatous anterior uveitis is the most common manifestation, and also conjunctival nodules. Blindness can occur if not adequately managed. Acute anterior uveitis typically affects patients with acute onset sarcoidosis. Chronic anterior uveitis, typically granulomatous, tends to affect older patients with chronic pulmonary disease. So it can cause acute anterior uveitis and also chronic anterior uveitis. The International Workshop on Ocular Sarcoidosis, reporting in 2009, identified 7 key signs in the diagnosis of intraocular sarcoidosis. The first sign is mutton fat capes. These are the mutton fat capes and are small granulomatous capes and are iris nodules like Coepi and Busaka nodules. Second is trabecular meshwork nodules and are tent-shaped PAS. So these are trabecular meshwork nodules. Out of 159 patients in one Japanese study, 61% of patients had trabecular meshwork nodules and 55% had tent-shaped peripheral anterior synecdoche, leading to abnormal gonioscopic findings. The third sign in the diagnosis of intraocular sarcoidosis is vitreous opicities, snowballs, which consist of snowballs and or string of pearls. Snowballs and string of pearls. This is a fundus photograph showing vitritis with snowballs, opicities in the peripheral retina. Here you can see in the peripheral retina, snowball opicities, vitritis, and this image also. Number 4 sign of intraocular sarcoidosis is multiple chorioretinal peripheral lesions. Multiple chorioretinal peripheral lesions, which may be active or atrophic. Choroidal lesions are uncommon, vary in appearance, multiple small, pale yellow infiltrates, sometimes punched out appearance, are the commonest and are often most numerous inferiorly. Multiple large confluent infiltrates are less common. Multiple choroiditis carries a poor visual prognosis even after resolution of activity as a result of secondary choroidal neovascularization associated with macular or peripapillary chorioretinal scarring. Retinal granulomas may also occur, seen as discrete small yellow-white lesions. These are retinal granulomas. And this was multiple chorioretinal peripheral lesions. Number 5 sign is nodular and or segmental periphlebitis and or retinal macroaneurysm in an inflamed eye. Periphlebitis appears as yellow or gray-white perivenous sheeting. Perivenous exudates, referred to as candle wax dripping. Candle wax dripping or perivenous exudates, also known as Intachys debauche, are typical of severe sarcoid periphlebitis. Severe. Occlusive periphlebitis is uncommon. So this is occlusive periphlebitis, which is uncommon, but peripheral retinal neovascularization may develop secondary to retinal capillary dropout. In black patients, it may be mistaken for proliferative sickle cell retinopathy. So this is a fundus photograph showing the perivasculitis. And there is solitary choroidal nodules. This is the sign of intraocular sarcoidosis. So optic disc nodules or granulomas or solitary choroidal nodules. They are less common than multiple lesions in sarcoidosis. Focal optic nerve granulomas do not usually affect vision. This is focal optic nerve granuloma. Persistent disc edema is a frequent finding in patients with retinal or vitreous involvement. This is persistent disc edema. This is a frequent finding in patients with retinal or vitreous involvement, and papillary edema due to CNS involvement may occur in the absence of other ocular manifestations. Papillary edema due to CNS involvement. So this is a patient fundus photograph showing the optic nerve head anastomosis in a patient with cutaneous sarcoidosis. The last sign is other ocular manifestations. They include conjunctival nodules resembling those of follicular conjunctivitis, lacrimal gland infiltration and dry eye, eyelid nodules, and orbital and scleral lesions. So these are the lower lid granulomas in sarcoidosis patients, and this is a lacrimal gland infiltration in sarcoidosis patients. This is a slit lamp photograph showing conjunctival granulomas in a patient with thoracic sarcoidosis. So also it can cause dry eye it can present as a dry eye, and also it can cause eyelid nodules. These are the conjunctival nodules representing granulomas in a 27-year-old woman with ocular sarcoidosis. Here also you can see these nodules, granulomas, and these are the iris lesions. These are keratic precipitates in a 27-year-old woman with ocular sarcoidosis and posterior synechies. So this is conjunctival sarcoidosis presenting as limbal conjunctival hypertrophy, anterior segment photography and histologic examination at presentation. So here you can see yellowish conjunctival hypertrophy around the limbus. Here multiple yellowish conjunctival nodules are observed. Conjunctival sarcoidosis presented as limbal conjunctival hypertrophy. So this is anterior segment photograph after treatment with topical cyclosporine. So here without treatment, and here with topical after cyclosporine topical. Complete resolution of conjunctival nodule is observed, and this is also after the treatment with cyclosporine. There is a fleshy yellowish conjunctival lesion. So it was biopsied, revealing non-caseating granuloma, and after subsequent systemic workup confirmed a diagnosis of sarcoidosis. These are eyelid nodules. Here you can see the eyelid nodules and orbital and scleral nodules. This is sarcoidosis and progressive diplopia and headache in this patient. Progressive diplopia and headache. Slit lamp photograph showing scleral nodule in a patient with sarcoidosis. What are the complications? So it can cause cataract, glaucoma, posterior and peripheral anterior synechiae. Chronic inflammation and hypercalcemia in sarcoidosis can also result in subepithelial deposition of calcium, leading to calcific band keratopathy, vitreous hemorrhage, maculopathy in the form of cystoid macular edema, epiretinal membrane, choroidal neovascularization, retinal detachment, and phthisis. Investigation. In addition to the acquisition of histopathological evidence, IWOS judged the following 5 investigations to be of significant value in the diagnosis of ocular sarcoidosis in patients having a compatible uveitis. So these 5 investigations are significant. Number 1, negative tuberculin skin test. In a BCG vaccinated patient or in a patient having had a positive tuberculin skin test previously. Elevated serum ACE levels, So in the first one, if a tuberculin skin test is negative in most sarcoid patients, a strong positive reaction to one tuberculin unit makes a diagnostic of sarcoidosis highly unlikely. Second point is elevated serum ACE levels and or elevated serum lysozyme is described for investigation of AIU. Chest X-ray showing bilateral hilar lymphadenopathy. Chest radiography is abnormal in 90%. Abnormal liver enzyme tests. Chest CT scan in a patient with negative chest X-ray result. So high resolution chest CT scan is of considerably greater value than standard resolution imaging. Other investigations are discussed. The first one is fiber optic bronchoscopy with biopsy. Histopathological confirmation of sarcoidosis is almost always required before starting treatment. The lung is a common site from which to establish this in the presence of clinical or investigational evidence of pulmonary disease. However, a more easily accessible superficial lesion should be chosen if available. Thoracic endosonography, endobronchial or esophageal with needle aspiration, has been shown in a large trial to be more sensitive technique than bronchoscopic biopsy. Miscellaneous biopsy sites include superficial lymph nodes or skin lesions, conjunctival nodules, lacrimal glands. Up to 75% of enlarged glands are positive. If the eye is involved, uterus biopsy is very useful for CD4-CD8 ratio. Other imaging modalities include MRI, cardiac, CNS imaging. MRI is less useful than CT for thoracic evaluation, PET scanning, and occasionally whole body gallium scanning. Calcium vitamin D level may be abnormal depending on the disease pattern and level of activity. Hypercalciuria is common. Pulmonary function testing. Bronchoalveolar lavage fluid shows characteristic changes. CD4 to CD8 T cell ratio are a key indicator. Induced sputum analysis correlates strongly with bronchial lavage fluid and is a non-invasive technique. 4 diagnostic levels were defined by the IWOS for ocular sarcoidosis. 4 diagnostic levels. The first one is definite ocular sarcoidosis. It is biopsy supported diagnosis in the presence of compatible uveitis. In the rest, presumed ocular sarcoidosis, biopsy not done, but chest X-ray shows bilateral hilar lymphadenopathy with a compatible uveitis. Probable ocular sarcoidosis, biopsy not done. No bilateral hilar lymphadenopathy on chest X-ray, but more than 3 by 7 of the intraocular signs above and more than 2 by 5 positive laboratory tests. Another is possible ocular sarcoidosis in which lung biopsy negative but more than 4 by 7 signs, more than 2 by 5 positive laboratory tests. So more than 2 by 5 positive laboratory tests and more than 4 by 7 signs. So more than 3 by 7 probable and more than 4 by 7 possible. It is crucial that alternative cause of the uveitis are adequately excluded by appropriate assessment and investigation. Treatment corticosteroids have conventionally been the major treatment modality in ocular and systemic sarcoidosis, though immunosuppressive are being used more commonly. Eye drops regionally in the form of corticosteroid eye drops regionally in the form of periocular, intraocular injection or implants, or systemically in the form of oral corticosteroid. Immunosuppressives are being used more commonly, particularly as steroid-sparing agents. And in refractory cases, treatment should be initiated aggressively to prevent sight-threatening complications. Treatment of anterior and intermediate uveitis is approached as a stepwise fashion as per idiopathic inflammation. For posterior uveitis generally requires systemic steroids, Occasionally immunosuppressive agents, methotrexate, azathioprine, cyclosporine, TNF inhibitors, for example, adalimumab. Conjunctival lesions, keratoconjunctival, Zika, topical cyclosporine eye drops, scleritis and orbital lesions, systemic corticosteroids, systemic immunomodulators, for cutaneous lesion and dilate above plus minus intralesional triamcinolone injection or oral chloroquine. For peripheral retinal neovascularization, scatter photocoagulation to ischemic areas demonstrated on FS, persistent macular edema or topical NSAID, cataract and glaucoma. Inflammation should be suppressed prior to surgery, preferably for at least 3 months in the case of cataract surgery.